Hi, good evening, everyone. Thanks for joining us. I know we have lots of people from overseas, so good morning. Depends wherever you are. Thanks for joining us for this series of webinars hosted by the American Interventional Headache Society. I'm very pleased to coordinate and moderate this webinar. This is special. It's only sponsored by our society. We have no support or sponsorship from any industry. I'm pleased to have Dr. Shalini Shah as the first speaker. She's the Vice Chair of the Department of Anesthesia and the Chair of the Pain Services at University of California, Irvine. She's well known to most of the people in the headache community. She will talk about peripheral nerve stimulation for head and face pain, why and which candidate. Then the next speaker will be Dr. Salim Haik. He's a professor of anesthesia and pain, chair of the pain department at Case Western University. He's also the president-elect for NANS. He will be followed, second talk, about evidence-based medicine in regards to neuromodulation for head and face pain. So I want to remind you that the link for the recorded material will be available tomorrow. It's free for whoever registered. And also be on the look for the next webinar, which will be in November. The title will be Post-Traumatic Headaches. We're trying to cover diverse primary and headache disorders that are relevant to our clinical practice. So without any delay, I will give the screen to Dr. Shalini Shah. Thank you.
Very good, everyone. Today we're going to be discussing peripheral nerve stimulation for headaches and facial pain, and really we'll paint a story of who best to serve, who best this will serve, and why. Okay. I do want to announce this the next webinar is part 3, which is on post-traumatic headaches, which is the date to be announced. So do stay tuned. My disclosures is that I'm a consultant for Allergan as well as Massimo Corporation, but I will not be discussing any of their products today. Okay, so what will we be talking about? Well, specifically for peripheral nerve stimulation, who does it work for? How does it work? And what is our efficacy data? So let me take you on a little story about the historical perspective of using peripheral nerve stimulation for cephalic neuralgias. In the 70s and 80s, Long, Nashhold, and others described the use of spinal cord stimulation, but for peripheral neuropathies. Subsequently, in 1999, Reed et al. Had the first case report of using occipital nerve stimulation, meaning a peripheral nerve a lead placed peripherally for occipital nerve stimulation. And from that, a series of manuscripts and studies were published over the next decade, which kind of divulged the peripheral nerve stimulation into 2 categories. One is for cephalic neuralgia, and the secondary is for primary headaches. So let's begin talking about cephalic neuralgia. From that Reed study of occipital nerve stimulation, we began over the next decade really evaluating its use for neuropathic etiologies, occipital neuralgia, C2-mediated head pain, cervicogenic headache. And typically all of these studies reported a consistent responder rate of about 70 to 100% relief. And what I mean by responder rate, I want to be very clear because I'm going to use that term many times in this presentation. By successful responder rate or success rate, I'm really talking about what we use as the historical standard of 50% relief in patients. Subsequently, there was a series of case reports about the application of peripheral nerve stimulation for the supraorbital facial pain, for frontal pain. Okay, Duteman in 2002, Johnson, Slavin in 2006, Amin in 2008, and interestingly, well, it may be interesting to you, but not to me, they also had a similar success rate of between 70 and 100%, just as we saw with occipital nerve stimulation. Subsequent to this, series of publications were made about using occipital nerve stimulation to treat cluster headache. And this is a landmark study by Dodick, and I really encourage you to see the report if you haven't seen it. Published in 2003, in which he described using occipital nerve stimulation successfully for cluster headache. Poppenet then published similar case report about results in migraine in 2003. Subsequently to this, most of the publications for headache, again, not cephalic neuralgia, but for headache, was published by a series of 7 teams principally. And they typically found a response rate for primary headache pathology of about 62%. And we'll contrast this with what we found in the peripheral neuropathies, such as occipital or trigeminal neuropathies, of a responder rate of about 89%, right? For any of you who practice headache pain or headache medicine, this should not come as any surprise, because if you evaluate essentially the mechanism of using peripheral nerve stimulation to treat other painful neuropathies in the body, such as in the torso and limbs, the mechanism is the same. And the success rate is the same, about 70 to 100% relief. But why is the success rate for headache pathology so low? For anyone who is interested in using peripheral nerve stimulation, the question of migraine always comes up. Okay, can this be successfully used in our migraine population? And this was really evaluated through a series of industry trials, very large or substantially large prospective RCTs led by Boston, St. Jude, and Medtronic, the 3 largest manufacturers, to evaluate its use in migraine. Again, I'm going to point out the historical standard for success is about a 50% improvement in either severity or frequency of symptomology. The Boston and the St. Jude study showed no significant evidence for positive improvement. The St. Jude study did note and did report on a decrease in VAS pain scores and decrease in frequency of headache days by 30%, and that 52% of patients were satisfied with at 12 weeks. But again, not the same 50% that we're used to using as our standard. The Medtronic OnStim reported a 39% response rate at 3 months, but you need to understand that this needs to be qualified in the context that their responder success rate was a benchmark of 30% improvement and not 50%. So taken as a whole, the largest studies that we see from using PNS for migraine did not have any success rate at the historical standard of 50% improvement for migraine pathologies. Our fearless leader subsequently did a very interesting study in 2007, which was the first published case report by Nowruz et al. Using supraorbital nerve stimulation to treat cluster headache. Okay. So this led to the belief that perhaps using occipital nerve stimulation and supraorbital nerve stimulation together may be beneficial for some headache pathologies or migraine pathologies that are hemicephalic in nature. Okay, because we're using, leveraging both our trigeminal and occipital neural systems. Subsequently, Reed again published in Cephalgia in 2009, a case series of about 7 subjects in which the combined use of occipital and supraorbital nerve stimulation produced results, very satisfactory results, in 7 out of 7 patients. In fact, 1 out of the 7 patients had complete resolution of their migraines using the combined system. So this is where I want to discuss, and I think Dr. Hayek will also discuss, the concept of concordancy. What I'm going to propose to you today is really based on the historical analysis of what we have just reviewed. Okay, the issue of concordancy shouldn't come as a surprise to you, because what drives success in using peripheral nerve stimulation for cephalic pain, whether it's neuralgia or cranial, is that you have concordancy over the paresthesias. Nothing new. The same applies to abdominal, cardiac, visceral pathology when we use peripheral nerve stimulation or spinal cord stimulation, right? So it's the issue of using concordancy. Remember that migraine has multiple generators, including neurotransmitters, which cannot be modulated necessarily with peripheral nerve stimulation. And that's why we see a lower success or a lower responder rate as compared to occipital nerve or trigeminal neuralgias. So here I have a very simplistic diagram of how the neurotransmission occurs. And for any of us who study headache and migraine, you must know this by heart. Most of this is done by the work of Peter Goadsby and his meticulous animal studies. So as you can see, your cervical afferents, your trigeminal ganglion, and your vagal afferents all synapse within the trigeminal neural trigeminal complex. right? So this kind of will give you a framework or a context to understand why in some patients, when you use the combined system of the ONS plus a supraorbital peripheral nerve stimulation, you will actually be able to treat some migraine or primary headache pathology. Trial response, false positives can occur. However, if you look at historically the data, less than 2% of the patients ever return to your office after a permanent implant, which seems to suggest your trial is of utmost importance. Your trial will really dictate whether or not you're going to have a responder. If your patient is going to respond, they're going to respond. If they're not going to respond, they're not going to respond at all. It seems to be what the data is suggesting, because less than 2% of your patients will return after a permanent implant. So from the first case report in 1999 for the use of ONS to now, we have extended that methodology to the frontal and trigeminal neuralgias to treat primary headaches, cluster, and some very selective patients in migraine. I'm going to qualify that because this is not for first line or second line use for primary migraine, but there are some patients that it can benefit from. The database does support an optimistic vision for the future of PNS and head pain. And I really want to emphasize the importance of paresthesia concordancy. And if you feel that your patient with migraine has typically occipital nerve pain, occipital plus frontal pain, they may be candidates for future research protocols. And with that, I will turn it over to Dr. Hayek to continue.
Thank you, Shalini. Excellent presentation. Let me figure out here how to share my screen. Okay, I think I'm on. So I would like to thank Dr. Naruz and AIHS for inviting me to speak. I was asked to talk about neuromodulation for head, neck, and face, evidence and new developments. I'll be focusing more on new developments. Dr. Shah presented an excellent talk and covered some of the evidence. Some of my slides may overlap with some of hers. I have no conflicts of interest related to this presentation today. Peripheral nerve stimulation recently in the modern age was initiated by two giants, Patrick Wall, who was a neurophysiologist and worked on the gait control theory with a neurosurgeon, William Sweet. And they published a paper in Science. Actually, it's a very short manuscript describing 8 patients with intense peripheral cutaneous pain that was neuropathic in origin. They delivered low frequency stimulation, and they noted that the patients became less sensitive during stimulation to pain. And not only that, the patients seem to have a carryover effect. If you read the last paragraph in here, it says 4 patients who had diseases of their peripheral nerves experienced relief of their pain for more than half an hour after stimulation for 2 minutes. So with that, modern peripheral nerve stimulation was born, and it was soon after that it translated into the head and face, and people have made use of the trigeminal cervical complex as eloquently described by Dr. Shah. This concept is based on the fact that synapses from the trigeminal nucleus proceed caudally and synapse with second-order neurons in the upper cervical spine. And that's where a lot of the sensory efferents from the occipital region, for example, the occipital nerve synapse also in the upper cervical spine at C1, C2, C3, making this a favorable area for intervening with neuromodulation approaches to control head and face pain. The first description of occipital nerve stimulator was done by Bob Wiener, who is a neurosurgeon at the time in Texas. And Dr. Wiener put in these occipital leads at the level of C1 and was able to describe pain relief we did a systematic review in 2008. The evidence was weak, and it was not long after that industry was interested in proving that occipital nerve stimulation can work. However, they went for the biggest market, which was migraine. And unfortunately, all the three studies by the major companies, including Medtronic, Boston Scientific, and St. Jude, had weaknesses in them. For example, the Boston Scientific study allowed patients who had medication overuse headache to receive the device. And despite that, there were improvements in the patients who received stimulation compared to the control group. But again, as Dr. Shah stated, none of the companies hit the primary endpoint, which was 50% reduction in pain. However, if you consider 30% reduction in pain, the Medtronic and the St. Jude study hit that. And the St. Jude study hit all the secondary endpoints, leading to CE approval. So in Europe, occipital nerve stimulation for migraine is approved. However, really the efficacy of occipital and craniofacial nerve stimulation may be more so for occipital neuralgia and craniofacial neuralgias as opposed to migraine. And craniofacial neuralgias, as you know, encompass a number of conditions, including trigeminal neuropathy, trigeminal neuralgia, some other neuralgias in the face, such as occipital, persistent idiopathic facial pain, glossopharyngeal neuralgia, cluster headache, and paroxysmal hemicrania. The incidence can be up to nearly 40 people per 100,000, with trigeminal neuralgia being the most common. The historical placement of the leads has been anywhere where the pain occurred, as Dr. Shah stated, and with the wires tunneled down, typically to the infraclavicular region where a generator was placed. Unfortunately, this had been somewhat inconvenient to patients because some of the patients were thin in the infraclavicular region. Sometimes there were generator erosions. So with time, there has been evolution of the system to the lead having an antenna which would act as a receiver, similar to the old radiofrequency receivers for stimulators, and whereby one could transmit from the outside through a little foam antenna a signal from an external battery and power generator to the implanted device, therefore circumventing the need for placing a generator and making it more convenient for the physician, not having to tunnel across the neck region into the supraclavicular region and having less incisions and a very low profile, so that the device can look something like this. This would be an infraorbital and mandibular region lead. If you look at the lateral view just above where the ear would be, you could see one of the leads has one dark contact and the other one has two darker contacts here. And these are actually where the antenna or the receiver would be for the lead to receive the signal. So the idea was that the patient would wear either the transmitter over their ear. The idea was to make also smaller transmitters, something that would look more like a Bluetooth device. And the sponsoring company initiated a multi-center study in the United States, which is expected to close in the next couple of months. I presented this data at the last NANS meeting in January. At the time, the goal was to get 65 subjects, and we had about 54, I think. Now there are close to 60, I think 60 patients recruited. There's still need for 5 more patients to be recruited. The patients recruited in the study do not include any migraine patients. Migraine is an exclusion criteria. The criteria are having either occipital or craniofacial neuralgia, basically trigeminal neuropathic pain. The patients are randomized to either receiving the continuous stimulation or after a period of 1 week being switched to a 3 months period without stimulation, and then the stimulation is turned on. So the patients all get the implant. There's no trial because it's a very minimally invasive device. The leads all have tines, and they are placed either in the occipital or supraorbital, infraorbital mandibular region where the pain is located. And the patients are either maintained on stimulation continuously, or the stimulation is interrupted after 1 week for 3 months, and then the stimulation is resumed. After that, the primary endpoint was at 3 months and was greater than 50% reduction in the original pain score. There were a number of secondary endpoints that had to do with quality of life and functional outcome measures, as well as adverse events. So again, the exclusion criteria would be migraines. The patient would have had to be included history of craniofacial neuralgia and have been stable on medication for at least 3 months. They should not have had anesthesia dolorosa or any episodes of acute shingles. The patients recruited here are shown up to the number 51. A patient, there were 25 patients who continued to receive stimulation from implant on, and 26 patients who received the stimulation only for the first week and then were stopped for 3 months, and then the stimulation was resumed. After that, there were no difference in the demographics between the patients. At 1 month visit, we had 41 patients completing this study. At 3 months, we had 41 patients, and then the numbers were lower because we're still collecting the data last January. The trial responder rate was high at 92%. Again, this was not a conventional trial, so patients went straight for the implant. And at the end of the 1 week period after implant, they were either continued on stimulation or the stimulation was turned off. At 3 months, the primary endpoint measure, 80% of the patients who received the continuous stimulation reported greater than 50% pain relief versus only 10% who were on the delayed stimulation. If you look at the pain scores here, you could see that the group with the continuous stimulation are in blue, and the group with the delayed stimulation are in gray. Initially, both groups have an immediate drop of the pain scores from an average of 7 to 8 on a scale of 0 to 10 down to an average score of around 2. And after the 1 week period, the delayed group are shut off of stimulation, and the pain score then increases for this group in gray, whereas it stays down for the group in blue. And then at 3 months, when the delayed group is turned back on, they recapture their pain relief. There were a number of secondary endpoint measures, including the brief pain inventory, which showed an improvement in the functional measure in the continued group versus the delayed group. Similar for facial interference, such as smiling, talking, opening the mouth, chewing, which was better for the continuous group compared to the delayed group. Similar improvements in outcome measures for the pain intensity on the brief pain inventory, as well as the McGill pain questionnaire and multiple dimensions of the pain questionnaire, the McGill pain questionnaire, as well as the short form of the McGill pain questionnaire. When looking at the global impression of change, also there was a significant improvement in the continued treatment group, who rated their pain scores at, who rated their global impression of change as 6 on a scale of 1 to 7, with 6 being better, whereas the group that got the delayed stimulation rated their global impression of change as 1, which is no change from their chronic pain before the implant. Unfortunately, there were significant side effects that, or adverse events that plagued subcutaneous peripheral nerve stimulation in the cranio-occipital region. As you know, this is an area where the skin can be thin, And we saw more of these complications in the multiple centers earlier on as physicians were getting used to using this newer lead. There were notably significant number of erosions, totaling 12. There were 6 lead migrations. Initially, also, there were problems with the device with 4 device failures. Over time, a lot of these adverse events actually improved, and some of it had been due to improvement in physician skills, and some of the other ones were due to improvement in the device itself. But in general, the continuous stimulation for these indications of craniofacial neuralgia resulted in significant improvement of pain scores, with 67% of the patients reported greater than 50% pain relief versus 9% of the patients in the delayed group. And there were improvements in a lot of the functional outcome measures and also in the patient global impression of change. There are, as you know, many indications for neuromodulation, and the craniofacial is only one of them, but one has to remember that neurostimulation is not neuromodulation alone. As pain physicians, we have access to other interventions, and that includes targeted intrathecal drug delivery. Before I talk about targeted intrathecal drug delivery and craniofacial pain relief, I would like to briefly discuss some of the physiology. We've all studied that CSF is produced by the choroid plexus and taken up by the arachnoid villi. And it was described as the bulk flow pattern. However, this is not a flow pattern like a fountain in your backyard that keeps recirculating. It's actually has been replaced by the pulsatile flow theory for CSF, which suggests that CSF moves in small to and fro movements that are governed by the Monroe-Kelly theory, which states that the pressure regulates the volume in an enclosed space, such as the cranium or the vertebral canal, so that CSF is subject to cardiac perturbations during systole. As blood is rushing into the brain, CSF moves away from the brain into the spinal cord, and during diastole, the opposite happens. As blood is moving away from the brain toward the heart, CSF seems to move toward the brain. And so we have this to and fro motion of CSF that occurs across the system, including in the spinal cord, with an oscillation of about 1 centimeter in amplitude, with the heart acting as the pump for the CSF oscillations. As a result of that, CSF is a poorly circulated system, and this has been shown by the late Chris Bernards, who did very elegant standing pig studies, whereby he would place a catheter in the posterior intrathecal space of the pig, and you can see here with a posterior placed catheter, most of the methylene blue stayed on the posterior aspect of the spinal cord, and very little went to the anterior aspect of the cord. In treating craniofacial pain, we use mostly bupivacaine. As you all know, it's an amide local anesthetic, which works by blocking sodium channels. Unlike opioids, you don't have to worry about tolerance because it's not a G protein coupled receptor mechanism. Bupivacaine has a sensory motor differential blockade. At lower doses, it blocks mostly the smaller fibers, which happen to be the pain fibers, but it can also block the small B fibers for preganglionic sympathetic, so sometimes you could see a little drop in the blood pressure. The predominant effect of the bupivacaine occurs at the nerve rootlets. It's not really penetrating the cord because it's much easier for it to penetrate the rootlets or the superficial regions where the sodium channels would be more exposed than the thicker cord. It is in combination with an opioid, a first-line treatment according to the polyanagestic consensus guideline, line 1B, after ziconotide alone or morphine alone, and usually in combination with either fentanyl or morphine or hydromorphone. I was interested in this publication that came from Scandinavia. In this study with percutaneous-based catheters, the authors looked at either high cervical or intracisternal placement of catheters and infusion of bupivacaine. Initially, they used 40 patients who had head and neck and face pain. There were 15 non-cancer patients and 25 cancer patients with these intracisternal or high cervical catheters. They used fairly high doses of bupivacaine that ranged from 0.5 milligram per hour to 5 milligram per hour. So you can imagine 5 times 24 is 120 milligrams per day of bupivacaine. We never recommend these high doses for the PAC criteria. And you can see also that the patient activated boluses range from 0 to 7 milligram. 7 milligram is almost is a dose for anesthesia. And so, however, one thing to remember about the cervical cerebrospinal fluid is that it's the highest circulated area of the CSF. But their mean doses of bupivacaine were between 10 milligram, and I'd say most of my studies have had an average of 10 milligram a day of bupivacaine, but their mean doses ranged up also to 58.7, which I would say was a fairly high dose. And you could see here in this table, the ranges were sometimes extreme on a daily basis. They reported improvement in this patient group with their pain scores and decreases in the daily uses. The patients had these catheters for days and up to weeks. I think the longest patient was a little shorter than a year. They detailed the reasons for discontinuation of the catheters and what kind of symptoms the patients had. So I was intrigued by this when I had a patient, local patient, but who has been all over the country because she developed this corneal neuralgia after having LASIK surgery. And initially she presented to me because her father, who's a physician, had heard that I provide ketamine infusions and wondered if ketamine would help. I thought there's no harm in it, but I didn't think it would help. So when she didn't have enough relief, she said, what do we do next? I suggested Gastirian peripheral nerve stimulator. So she had it with one of our functional neurosurgeons. Initially, she thought it helped her, but after 3 months, she developed tolerance. And despite revision of the lead, she continued to have the pain. And I have to give the patient credit because she was persistent and she said, what next? I said, well, this may be crazy or experimental, but you can try having a catheter placed with a pump with a catheter tip at C1, C2 or intracisternal. And she surprisingly was very adamant to have it. So we did place the catheter at C1, C2. She did great. However, when the catheter migrated back to C2, C3, she lost the efficacy and it was revised actually. And she did good. And the reason this worked, again, was because of this trigeminal cervical complex. If you look here on the screen, you can see that where the synapses are for the trigeminal cervical complex are very, very superficial. And therefore, it is likely that at this location, bupivacaine, and also we used a small amount of fentanyl, would work. But it's very, very critical that one uses very accurate catheter placement, because if your catheter placement is not accurate, then it is unlikely to capture the pain relief, or if the catheter migrates. Lately, we've been placing the catheter either right into the cistern or at the C1, at the most C1, C2 junction would be the lowest point where we would place it. We have had a few patients, one with supraorbital neuralgia, another with infraorbital neuralgia. And I would have to say all of these patients have been refractory to peripheral nerve stimulation. It's also important to pick the right patient who is psychologically stable. However, it's also important to consider the medication that you use. Both these medications, fentanyl and bupivacaine, are off-label for intrathecal use. However, both are fairly safe. The amount of fentanyl that we use does not exceed 25 micrograms in a day. If you look at the OB literature, that's the maximum dose that had been effective in single dosage in labor pain. Above that, I think you would have, with fentanyl being highly lipophilic, high vascular uptake, and it would be as similar to giving fentanyl systemically. Fentanyl is advantageous in the sense that it's not inducive of intrathecal catheter granulomas. Bupivacaine also works very segmentally, so therefore it's important to place the catheter at the appropriate region. I have to say that most of our patients require a lot of self-administered boluses, and even though I provide this to all the patients that receive pumps, I would say the average patient in the low back uses between 3 and 5 doses a day. The patients in the cervical region can use up to 40 boluses per day, and it's not unusual. And this has happened in a number of them. So, in conclusion, peripheral nerve stimulation and/or targeted intrathecal drug delivery can be potentially used in patients with refractory craniofacial pain. It is important to select the patients carefully and to target the therapy to exactly where the pain is located. And with that, I would say thank you, and we'd open up to questions and answers.
Thank you very much. Thanks, Dr. Hayek and Dr. Shah, for this great presentation.
Samir, you're breaking up.
Any experience with high cervical stimulation for facial pain?
Spinal cord stimulation?
Yeah, upper cervical stimulation, yes.
Yes, I've, I think there has been maybe one publication to a case or case series. I've done that for occipital neuralgia, and it has worked with a high cervical spinal cord stimulation. Actually, as a matter of fact, there was a patient that Dr. Giancarlo Baralat had tried in Denver, but the patient is from the local area here. And he referred her to me for the implant. And, it was very difficult to get it to be approved by the insurance company. But finally, when it was approved, the patient has had very, very good pain relief. So high cervical spinal cord stimulation can be helpful for, in my experience, had been in one patient with occipital neuralgia, but I defer to you if you've had any success with the classical headache syndromes like a migraine or something.
No, honestly, I had only few, just one hand of cases, but I'm in private practice now, so it's extremely difficult to get these cases approved now. And my issue was it's not reproducible. I had a couple of patients, they did amazing with the trial, and then with the permanent implant, it did not. We did not find the perfect spot. So it makes me think maybe the trial was just a placebo, or sometimes those patients are desperate. So
right.
Whenever I try something, it helps. This brings me to another question, maybe for Dr. Shalini and you. Do we really need a trial before cranial neuromodulation or occipital neuromodulation? Do you feel sometimes that the response might be delayed, like deep brain stimulation, maybe a few weeks after? So, what do you think about that,
Shalini?
Dr. Shalini?
The reports I've read, my perception is that you must do a trial. It's a very low cost, very low barrier to seeing if the patient's going to have any response at all before you put a lead in the head, which Dr. Hayek showed, 12, 13, 15% erosion rate, or incisional pain rate. So from what everything I have read is that there's very low risk, and you learn a lot.
I agree with Dr. Shah. However, with the new technology of using this battery-free system, the trial is almost redundant because you're almost doing the same thing again. However, if there's one patient population where you skip the trial, and that's in cluster headache, in this patient population, the response to stimulation, pain relief is delayed. So patients really weaken their response at like 6 months after implant. And so in this patient population, some experts have recommended going straight to an implant in the cluster headache patient population.
You know, it's a really interesting point you bring up, because if you think about peripheral nerve stimulation for other etiologies or other locations, we typically don't trial. You do a local anesthetic block, you see if they have any relief, and then you move on to the implant. So sometimes you don't do the trial for some type of patients. That's really great.
Yeah, I want to make my point clear that I was referring to peripheral nerve stimulation because recently the FDA sent letter to physicians mandating trial before spinal cord stimulation. So I was talking more about special cranial nerve stimulation. So there is another question here about how high could you place your intrathecal catheter for craniofacial pain?
Yeah. So, I mean, obviously, once you get into the cervical region, or even before, I mean, you're placing the catheter under live fluoroscopy, you have to be careful, especially with a stylated catheter, if you push it too hard in the brainstem area. I have just ventured past the C1 slightly. Now, I have to state that there are trials in Australia going on now for intrathecal delivery of valproic acid for refractory migraine. Initially, the neurosurgeons have done that intervention through a intraventricular catheter placement for valproic acid for refractory epilepsy. However, they found that with an intracisternal catheter, you get the same effects. And so therefore, it may be that this may be the preferred placement is intracisternal. The CSF circulation in the high cervical spine, in the cervical spine in general, especially at C1, is the highest. And that also is fairly high in the cistern. I think it mixes well over there. I've only stopped in the lower aspect of the cistern. And the reason I go into the cistern a little bit is because sometimes as you are securing the catheter, it tracks a centimeter or so. And so you don't want it to pull back down. If you go below C2, I think you can lose capture of the pain control in the head.
Reviewing your slides, maybe I missed it. You were mentioning you are using local anesthetic and fentanyl. Any experience with ziconotide?
That's a great question. I think I would like to use it. You know, I like ziconotide in peripheral neuropathies. I use it in patients who have diffuse peripheral neuropathy who fail stimulation, and it works great in these instances. I have not used it with a high cervical catheter. As you know, ziconotide has a number of neurocognitive side effects. According to the PRISM study, which was sponsored by the manufacturer of ziconotide, the side effects are lesser if you use ziconotide first in the pump, but still the return rate was huge. A lot of the patients who have these issues, as you know, Samer and Shalini, they have a lot of other psychiatric issues such as depression, etc. And these are fairly relative contraindications to ziconotide. If I place ziconotide, I would not be too keen on exact catheter placement because, as you know, it's a peptide and it may move. So the short answer to your question is I have not tried it, and that's just because I have had so far this with this other intervention. That doesn't mean that ziconotide may not be a good option. I just fear the high incidence of neuropsychiatric side effects is what detracts me from using it more often.
Follow-up question. Your presentation with the if you're using fentanyl and bupivacaine and you have a migration of one level, why do you suspect that it stops working, especially knowing the lipophilicity of fentanyl?
Yeah, so lipophilic drugs tend to stay very, very close to the catheter tip as opposed to hydrophilic drugs. So that's why you have to really place it very accurately. I mean, if you're using morphine, I wouldn't worry as much about it. But the problem is, and you know what, we may be able to use morphine up there, but I didn't want to risk it, risk of granuloma. That being said, I think the risk of granuloma is going to be really small over there because I think the circulation, the CSF circulation is the best, is the highest in that region of the body. The CSF flow is very turbulent in that area compared to elsewhere in the body where it can be very stagnant.
There is another question from Dr. Ramos. He's asking any experience with neuromodulation for SUNCT, SUNCT, which is a form of trigeminal autonomic cephalalgia.
Yeah, I don't get those patients. Maybe Samer gets them more.
I can answer this. SUNCT it's like cluster headache, but they are very short lasting. They are very frequent and short lasting. Thankfully, they usually respond well to Anderson and to sphenopalatine ganglion blocks. Again, before insurance companies become very strict, I was able to get approval for sphenopalatine ganglion neuromodulation. I know now they have a new device that's approved in Europe, but not in the USA yet. I think they are about to publish the recent study, but it's not commercially available, and it's placed orally with an incision in the gingiva, and they just slide the electrode into the trigomaxillary fissure, through the fissure into the fossa. So I think this will be an option because this is a parasympathetic mediated headache disorder, autonomic headache disorder, mainly parasympathetic. So if any, I would consider parasympathetic intervention. But they are rare, they are very intractable. But I mean, as I said, most of them now, they respond well to Anderson. And actually, I'm trying, although it's not approved for the indication, the new CGRP medications. Actually, they work very well for trigeminal neuralgia and different cephalalgias, but it's off-label. Okay, yeah, actually, it's not a question, it's a comment from Dr. Samuel. Actually, I like this comment. I think he was trying to respond to the issue that we said the neuromodulation is not reproducible. You get good luck with the trial, but not the permanent implant. So he's saying that's why he does staged trials in his practice. So he tunnel the trial to the left, whatever, and if it works, then he used the same lead for the permanent implant and tunnel it on the other way. I think this is the way, but I don't know if you need to admit the patients or you are comfortable to send them home and you don't worry about infection. I don't know. I think, do you do stage trials, Salim or Shalini? I think we used to do it at Cleveland Clinic years ago, but I'm not aware if it's a common practice now or not anymore.
I actually meet more with the neurosurgeons. They'll tunnel their leads, keep it there, and then bring them back to the operating room. But I haven't done that technique.
But inpatient, right?
No, outpatient.
Outpatient.
Okay. So the stage trials have been shown to have a higher incidence of infection, at least in Europe, especially where they keep them for a longer period of time. You know, we use stage trials only in patients who are anticoagulated, and there's a high risk for keeping them off anticoagulation for a long time with a trial. And so that would be the only time we would do a staged trial to implant.
Okay. I think we addressed some of the question you addressed already in the talk. I have one last question about securing the lead for the trial. I mean, most of those prefer neurostimulation companies. They don't have like an anchoring system, and they recommend just to stitch it to the skin And I found this is really not practical at all. The lead migrates from me, so I glue it, I tape it. Sometimes I get an anchor, I open a kit from spinal cord stimulation, get the anchor. So how do you do it? I know it's very practical, but I think people might benefit from your experience.
So lately, my experience has been with this trial using the what's called the stim relief devices. They're basically tined leads, so they would not move, but you are also able, past that antenna dot there, you're able to suture through the lead itself into the fat.
Through the lead.
Through the lead, yeah. And so that has made it really, really, really easy. And in my hands, I have not seen migrations. But you're right, most of the, what we have used historically are these percutaneous spinal cord stimulator leads, which were never designed to be peripheral nerve leads. And nowadays, I think the combination of tines and the fact that you can take a stitch through the lead itself has made it really very favorable for usage. I use those leads for superficial radial nerve injuries, for neuropathic pain around the knee. It's very convenient because you don't, like, if I had in the past, I've implanted leads next to the superficial radial nerve, and I would have to tunnel across it, make an incision across the elbow and across the shoulder, and to put a generator in the infraclavicular region. And nowadays, you don't have to do any of that. You know, the patient wears an external device and stimulates, and you just put a small wire under the skin. And these wires are powerful because you're able to do different modalities of treatment, and they're multi-contact, multi-channel electrodes, not a single monopolar or unipolar contact.
I'm sorry, I want to repeat what you said again. You suture through the lead, but this is with only one of the companies.
Correct.
Okay, so I just want whoever listening, it's not for every company.
Correct.
And we are not sponsored by any of them, so we can say whatever we want. But yeah, because some of them, I don't think you can do this. But yeah, I will check with you because this is interesting. Because yeah, it won't move if you suture through it. Samuel commented back on this stage trial, and he said there is a difference between infection and colonization. Definitely, there is a higher risk of colonization around the catheter, but it might not be translated to frank infection.
Yeah. So, you know, I refer to the Belgian regulations of having the trial for a month. In this, yes, there's a higher incidence of infection. You know, anytime you go over 2 weeks, there's an inflection point at 2 weeks. For example, if you look, even with a clinical study, you know, when Zaconitide wanted to be tested initially when it came out, because you had to do the slow titration. They did this study by Verdonk and colleagues, and they had a 14% incidence of meningitis in patients whereby the catheter was left for longer than 2 weeks. So there was some inflection point at 2 weeks. So I think if you restrict your trial to 10 days or 2 weeks, you know, Sam is right. If you may have colonization, but hopefully no increased risk of an infection.
All right, so I think we're coming to the end. If there is any question that I missed, please send them to on the AIHS website, and we'll make sure we address them, or I will ask Dr. Shalini or Dr. Haik to address them. So again, thanks Shalini, thanks Salim for joining us, and have a great rest of the night. All right, thank you.
Thank you.